Hey y'all, this is Casey Lee. Thanks for tuning into the Buzz Podcast presented by Quality Rehab Management, where we are dedicated to sending out quality, up-to-date information to share with your therapy teams and your nursing home providers during the COVID-19 pandemic. And I am a physical therapist and on the quality team with QRM, and I've been focused on caseload management. And if you've listened to previous episodes, I've talked about this quite a few times, that we need to really think about limiting the number of therapists that come in contact with our highly vulnerable population during this crisis. But these patients, our patients, still absolutely need therapy services. Therapy services are what are going to keep them healthy, strong, out of the hospital, and strong enough to, in the event that they get the virus, that they can fight it, right? We're an answer to keeping patients strong, healthy, well, so that if it happens, their body is prepared to be able to take on the fight. So we know that the frailer a patient is, the less likely it is they survive. So we are essential to strengthening, conditioning, improving functional mobility, reducing fall risk in their discharge environment, improving safety awareness, environmental modifications. We are essential. But right now, we may need to think about being essential one at a time so that we're not all in at once, increasing the number of people that come in contact with this highly vulnerable population. Because we know that the more people that each person comes in contact with, the more chances, the higher the likelihood that they come in contact. We become a vector for transmission of this virus. Certainly not intentionally, but this is how it's spreading. And even the American Healthcare Association, in their guidance to therapy personnel in long-term care facilities, their recommendation is to reduce people traveling in and out of buildings, and if you are a floating therapist, to reduce or limit your travel between facilities. And that was the topic of yesterday's episode, how to make that work if you are a therapy provider that uses floating therapists. So check it out if you haven't already for some strategies. But today I want to talk about caseload management, and I'm going to offer, just from the patients' cases that I've audited this week, right? I've been reviewing documentation. I've been looking at our company overall. We serve clients across the country, and lots of rural, urban, big cities, smaller cities. We're in every pocket. I really feel like we cover all demographics of nursing home providers, nursing home facilities. So I like collecting data for our entire group because I feel like it's pretty comprehensive. And what I'm finding is our therapy teams have taken on the challenge of modifying their caseloads. So I applaud them for that first, because I see it. I see that the caseloads are coming down, meaning there's less patients that are being seen by all three disciplines or more than one discipline at one time. I can see that effort being made. I can also see that the care plans have been modified to support essential goals only, where maybe we let go of dynamic sitting balance or activity tolerance in standing. We're letting some of those non-essential goals go and keeping the essential functional goals. We're keeping it focused on the functional tasks that patients have to be able to accomplish safely and effectively in their discharge location, whether it's long-term care, assisted living, independent living, or at home with a caregiver. So I see that effort, and that's I'm going to offer is there are a couple trends that I do see that I believe are the next opportunity for us to consider to limit the number of therapists that come in contact with this highly vulnerable population as we move forward, as we get more cases. Like right now, today is the 27th of March, Friday, and it's kind of quiet. I believe it's the calm before the storm, and that we are going to see a lot of quick, fast admissions into our nursing homes in coming weeks. And so at that point, I would love for our teams to be already thinking this way and already using these strategies so that it's second nature, no question, no education needed at that point, right? We're just going to do it this way because it's the right way for the current state of events in our country. So there are types of patients where it's going to be challenging to argue that PT, OT, and speech are not justified for the entire episode. So I want to focus on, to me, the patients where I think we've got a good case to support one discipline at a time. And there's three cases that I see pretty consistently where I think we could consolidate and say, okay, it's the PT show, it's the OT show, it's the speech show, and everybody else back out, okay? And those three types of cases are discharges to long-term care, so a skilled rehab patient that is going to be returning into the long-term care population with caregiver support, nursing and CNA support. That's one. Your higher level patients at admission, so your patients that score very well on their Section GG functional assessment. So they have a very high GG score. They're scoring supervision, setup, or independent in most all categories. You know, we have lots of patients like that. They're super fun to work with. You get to take them outside and work on all sorts of fun dynamic standing and balance training and fall prevention. They're really fun to work with. But they're out there. And then the other side are your very, very lower level patients. The patients that score close to or around a 0 on the Section GG mobility scale. So those are the three types of patients I want to work through and talk about and offer as patients to think about when they admit right now, when it's the calm before the storm. Let's start thinking about, could one discipline take it, offer the services that this patient needs, the essential services that this patient needs, and the other disciplines take a step back for now. So for the patients returning to long-term care, I think it really comes down to what are the essential functions of that patient in long-term care. If you have a patient who, and also thinking about why did they go to the hospital, or what is their reason for skilled services in the first place? If the reason for their skilled services is choking, aspiration, pneumonia, in that world, it sounds like the speech show to me. Let's focus on reducing risk of aspiration, and speech can focus on dysphagia and oral motor skills and eating. safely, safe swallow strategies. Possibly, if it's appropriate after speech, maybe OT piggybacks in to address self-feeding, eating the section GG item for eating. Okay? If the long-term care patient is skilled because they sustained a fall and an injury, maybe a fracture or a non-fracture fracture injury, because they are unsteady with transfers or unsteady with gait, possibly in that case, we're looking at more of a PT case. And PT runs the programming for this patient from a skilled perspective. And if it's an injury, we could say an injury again, and this time it's affecting the upper body. So maybe it's a patient that is wheelchair mobile, sustained a fall, maybe they fell out of bed, it was unrelated to a transfer or a balance issue, and they have fractured their shoulder or injured their arm, and that is impacting their ability to dress, to perform grooming and hygiene tasks, to brush their teeth. That might be a patient that's more appropriate for OT. So this is not going to last forever, y'all, but right now we are trying to limit, number one, COVID-19 from getting into your buildings, and then number two, if it gets in, keeping it from spreading around. And we know that we can be vectors, and we also know that sometimes the symptoms are not obvious, and those of us, we might be walking around without symptoms, but contagious. And so the less people that come in contact with our population, the better. They still need rehab. We are essential. We're going to keep them strong. We're going to keep them healthy. We're going to improve their function. But can we do it one at a time? Not always. Not suggesting that. There are times where one at a time isn't going to work. And we'll figure it out. But if it can be done one at a time, this is the time to try. And I would start thinking about it and trying it now versus when we're scrambling for staff and we're getting inundated with higher acuity patients every single day. Okay? So that's the long-term care patient option. The other two options, it's kind of the same thing. It really goes back to, why are they skilled? Why do they need a skilled level of care? If it's due to a fall because of a balance issue or a balance deficit, I would say that's probably more PT. Let PT take it. If it's more safety and problems in an ADL environment, like a fall in a bathroom or coordination problems when showering, then it's probably more OT focused, depending on what their need for skill is. And if it's related to medication mismanagement, safety and judgment problems, cognitive issues, dysphagia, aspiration pneumonia, choking, that would be more speech. So what was the reason for referral? What is the reason for their skill? If they're skilled for rehab, why? Is it because they have functional mobility problems related to section GG? And if so, is it more of a mobility problem? Is it more of a self-care problem? Most of the time, it's going to be a combination of both. But is there more of a mobility problem than a self-care problem? More of a self-care problem than a mobility problem, right? This is the time for us to really be thinking critically about every single case. And there are going to be times where OT you might be taking some things under the PT umbrella, right? This is not the time for us to hoard our skills, right? There is some gray, and there's some opportunity for us to share and collaborate and work together as a team. So there's going to be times where OT is going to take a couple tasks that might have fallen under the PT umbrella, and vice versa, right? PT. I was just reviewing a case where PT and OT were both seeing a patient, and PT was working on transfers and walking skills. And it looked like OT came in after the PT eval'd for maybe a week to address neck and shoulder pain. It wasn't clear in the documentation, but my suspicion is that PT referred to OT because that's what we do. We help each other out. PT recognized that the patient had shoulder restrictions, and that was irritating the neck because there were range of motion goals for the shoulder and pain management strategies goals for the neck, which are beautiful. Guys, I loved reading both of these plans. It's a joy for me to read something that makes so much sense, right? We pick up on PT, we're doing more, we're weight bearing through the upper body because we're using a walker for ambulation, and yep, that caused and triggered some shoulder and neck pain, and now we've gotten OT involved. It makes complete sense. So I love that. But I'm a PT. I can work on the neck and the shoulder. So maybe I just take it this time. Next time, OT, you do this when there's no more COVID-19 and we're not trying to reduce risk of spreading the virus. That's all you. But right now, maybe I just keep it and I let OT know, hey, I was thinking of you, but I'm going to keep this one today, and next time, all you. That would be how you might want to approach that. So I hope you find this information helpful. Again, there's 3 types of patients that I'm seeing a trend of multiple disciplines treating right now. March 27th, during the COVID-19 pandemic. And I think that there might be some opportunity for us to really look at these types of patients and streamline services that we provide to one discipline. And those are your long-term care patients that are going to be transitioning to long-term care, your high-level patients that walk, that perform most of their ADLs at a supervision contact guard level, kind of more safety type of a patient, safety cueing strategies. And then your low-level dependent patient that's likely going to need caregiver support upon discharge. One discipline can focus on the tasks that patient is going to need assistance with, and providing the patient and the caregiver the support and training that they need upon discharge. So I hope you found this helpful. Thank you so much. As always, reach out with questions. See Lee at QRMHealth.com, and have a great rest of your day. I will chat with you soon. Thank you.